Let's switch over to our second segment, which is on NMCRPC, or non-metastatic castration-resistant prostate cancer. For the urologist, this was index case 1, the AUA CRPC guidelines. And what I think is absolutely astounding is that prior to these 3 trials that we're going to address right now, and I'll ask Alicia to first talk about some of the metrics for qualifying for what is NMCRPC. We've gone from having no level 1 evidence for NMCRPC patients, or what we historically called M0 CRPC, and now we have 3 approved therapies. Rather an amazing development in the last couple of years. So Alicia, what was some of the kind of, how did we define this group and these 3 different trials that included them?
Absolutely. So these were patients who had definitive local therapy in the past, whether it's prostatectomy or radiation in the past, and were being monitored and follow up with a PSA that was consistently rising, with a repeat confirmatory rising PSA after their treatment. And we know that the definition of biochemical recurrence is different between surgery and radiation, but these patients met those criteria and had their rising PSA. What was really important to note is that by conventional imaging, which would be a standard CT scan of the abdomen and pelvis, and a bone scan, technetium bone scan, these patients had no evidence of metastatic disease, although in the Spartan trial they could have had up to 2 centimeters of pelvic lymph nodes. In the other trials they had absolutely no evidence of measurable disease or bone disease on that imaging. What was important to get into the trials, and what I think about actually in clinical practice, is that their PSA doubling time had to be 10 months or less, and this can be calculated in calculators that are online. I usually use one that's related to Memorial Sloan Kettering, but you can go in and plug in these numbers and actually look at that doubling time. If it's greater than 12 months, we actually have some data to suggest in biochemical recurrent populations and in the non-metastatic CRPC population that these patients are less likely to die from prostate cancer or develop metastatic disease. So it really is that patient population with a shorter PSA doubling time that was included in the trials and is the group that I think about treating now that we have data for prolongation of MFS.
Yeah, well, I routinely check the doubling time. It's interesting. We'll get into the trials in a second, and we'll talk about how do you pick based upon AE and if there's any difference in the trial designs or the MFS data. But I have a scribe, and that person will calculate it for me while I'm talking to the patients. I still think a lot of folks are still doing back of the envelope calculations, which I think is probably, what are y'all doing?
That's exactly what I do. It's actually interesting. We're going to talk about the design, right? So, because it brings a lot of these space, the M0 CRPC space is defined by how we actually practice, right? Not only, because even though we only took patients who had a PSA above 2, for instance, PSA doubling time less than 10 months, when you go to the approval, it depends how soon you start patients on hormones, right? And you're going to develop castration-resistant disease if you start them on hormones sooner rather than later. So there are some groups out there who actually hold tight. They don't start on ADT until his PSA is 5 to 10 and is moving rapidly with a short doubling time. Others will start right away, and so that's one thing that will define how big is your population. The other factor I would argue is, depends how you're scanning these patients, right? Because if you start using, these novel imaging with PET scanning, whether it's flucyclovine or PSMA, with more sensitive scans, you're more likely to find metastatic disease in that space. And then they are M1 CRPC and not M0 CRPC, but that M1, they are still M0 per conventional scans, but M1 by novel imaging, which creates another layer of questions to this setting. So, but it is a very interesting setting, but I would argue it's quite different depending on where we are actually practicing. To answer your question about how I calculate it, I actually do that. I do it I still use my pen and kind of practice my math and see where we are.
So if you're following a patient who's got a rising PSA, well, first of all, when do you get your first series of imaging scans, conventional scans, CT scan, bone scan? When do you do it?
So I have the luxury of working in an environment where I have the ability to have a PET scan available. I don't have the best scan in the world available in terms of sensitivity. I have the second best. So as we know, we have head-to-head studies showing that PSMA is the most sensitive compared with flucyclovine. We know that flucyclovine PET scan is better than conventional bone and CAT scans. So if you look at the data in terms of sensitivity, you will know that if you're going to use flucyclovine for the most patients, which is FDA approved here in the United States, you really see that number 2 is not as a magic number, but you know once you have your PSA above 2, your sensitivity, your chance to find metastatic disease is going to be perhaps higher than 50%. So if you're using a PET scan with a PSA of 0.5 or 1, you're much less likely to find metastatic disease. I'm not an anxious guy, and that's how I'm biased by the way I was trained. So I usually wait, and I don't start them on a systemic therapy before my PSA is above 2, 3, 4 sometimes, depending how quickly. So I know what's going to happen in the next few months, or try to predict at the best I can. And so saying those, using those 2 factors, right? So I usually wait and I stage them first. And after I get the proper staging, I define how I'm going to treat them next, which usually, if I don't have metastatic disease, includes using ADT. And again, if I have disease under control, as Alicia was mentioning, the prognostic risk factors, if you will, I feel very comfortable oftentimes doing an on and off strategy, an intermittent strategy, right? Where you do an induction period with testosterone suppression, you get a beautiful serologic response, you hold tight, you wait for your testosterone to recover, usually months or years later, and then you resume that therapy.